Yogi episode 2. To start with, we have a Saraswati Vandana.
सरस्वती नमो नमः मा सरस्वती नमो नमः विद्यादायिनी नमो नमः हंसवाहिनी नमो नमः ॐ सरस्वती नमो नमः मा सरस्वती नमो नमः विद्यादायिनी नमो नमः.
So, to give the welcome address, I would like to call upon Dr. Madhuri Patel. Can I please have a CV, Maria? Yes, Dr. Madhuri Patel, ma'am is no stranger to any of us. She is the editor-in-chief of JOGI. She is secretary journal of FOGSI. I request madam to please give the welcome address for this Clinical Pulse of JOGI second episode.
Thank you, Pragna, for your kind words. Respected our chief guest and President FOGSI, Dr. Jaideep Tan, my mentor, Professor C.N. Purandare, our another chief guest, Dr. Nandita Palshikar, my dear friend, and we are together since last 3 decades, more than that. And guest of honor, Dr. Suvarna Khadilkar, who is also one of my best friend like Nandita, and we are together since last 35 years. And we have worked together not only at JJ but also in a FOGSI organization. Then we have chairperson Dr. Arun Naik, Dr. Mala Srivastav, Dr. Sushil Chawla, Dr. Adi Dastu, Dr. Geeta Basarkar, Dr. Sujata Dalvi, Dr. Anaita Chavan, Dr. Ashwini Balerao, Dr. Pragna Changade, and a secretariat team, Dr. Pragna Supe, Dr. Gaurav Desai, and Dr. Sunil. My national corresponding editors are Dr. Lakshmi Shikande, Dr. Alka Pandey, Dr. Krishnendu Gupta, Dr. Madhava Prasad, Dr. Radhika Aiji, Dr. Sampat Kumari, Dr. Krishna Kumari, Dr. Ashok Kumar, Dr. Kiran Mai, Dr. Ramni Devi, Dr. Shobha Guri, Dr. Subhash Chandra, Dr. Dipti Gupta, Dr. Didi Gupta, my peer reviewers and my dear friends. Very good evening to all of you. It is with great pleasure I welcome you for all our second episode on Clinical Pulse of JOGI, an initiative by our JOGI team. I must say that before taking over as an editor-in-chief, I was in America, and I realized that our FOGSI authors or the presenter, they present at conferences and different platforms, but they are not given such a big platform to present their work. So I conceptualized this idea over there and thought, okay, why not to give them a big platform like our JOGI and FOGSI to present their work. So it will be, many people will know what they are doing, what is their research, and how it is implemented in a clinical practice. So with this, we started our Clinical Pulse of JOGI, that is FOGSI JOGI web series. We had first episode on 20th of March, that is last month, and it was very well appreciated. Everybody, not only by Dr. Jaideep Tan, by Dr. C.N. Purandare, then Dr. Lakshmi Shikande, Dr. Sujata, and Dr. Krishna, they were the chairperson, and Suvarna, Geeta, and everybody appreciated that program. The author got chance to present, and it was a very, very interactive session. We had 346 registration at that time. Then our whole idea is that we invite 2 authors with their original work. We thought of giving, this author how to select. So we decided to select 2 authors who have received the JOGI awards. And after that, we will select awardees from the Springer, and then we'll see the good publication who has maximum citation, which will be decided by the editorial board. So this way we have selected our speakers, and today's speakers, Maria, can you go ahead with the next slide? Maria, can you switch over the next slide?
1 second, ma'am. It has got freeze. 1 second. The slide got
Now, so today we have two award-winner articles. Previous one. One is in a senior category and another in junior category. In senior category, Dr. Mahesh Asalkar will present his award-winning article, Prevalence of Maternal Mortality and Clinical Course of Maternal Death in COVID-19 Pneumonia, a cross-sectional study. In a junior category, Dr. Maitri Parulekar will present analysis of maternal factors impacting neonatal near miss event or tertiary care experience. Let me reiterate that this week series definitely offers the authors the great platform, and we have excellent opportunity to gain new insight into the article and engage in meaningful discussion with the authors. This will also motivate our junior to publish more and more paper, and they can take some ideas of our published paper like these authors, and they can start with the research work. So I acknowledge Dr. Jaideep Time, who encouraged me and our team to present this web series to all of you, and I'm really thankful to him. I would
उनसे
also
बोलो
like
रूम
to,
देखेगी
I would
और
also like
दूसरा
to
ये
give,
उसे देखो
can you mute
उसने वो
yourself?
भेजा था
Can you mute yourself? Yeah. I would also like to have inputs from all the delegates and all the faculty, so we can improvise our next episode along with that. I also take the opportunity, Maria, next please. Maria, next please.
हाँ madam, 1 second ma'am.
I also take the opportunity to announce the JOGI cover design, cover page. So what has happened, I want to change the cover because that is his 6th year. So what we thought that we can take the inputs from all our members and peer reviewer to design this cover page. And we want you to send to our journal obgy@gmail.com before 10th May, and we can announce the result on our 3rd episode on 15th May at the time of Clinica Pulso Yogi webinar. So all the design, this should be original design, there should not be copyright issue, and all the people, all the editorial board members will judge this design and will give the certificate to the winner, as well as we will publish FOGSI page of journal. And if we really like that design, we can forward to our professional person to design the cover page. So I'm really I want all of you to take part in designing this cover page and come forward and send this original cover page by 10th of May to journalobgy@gmail.com. With this, I invite Dr. Pragna Shangade to introduce our Dr. Jaideep has joined.
Yeah, Jaideep is here. Jaideep is joining.
Yes. So with this, I invite Dr. Pragna Shangade to introduce our chief guest, Dr. Jaideep Tan, for his pulse of wisdom.
So happy Ram Navami to all, and welcome everybody to this FOGSI Yogi Clinical Pearls program. I welcome the chief guest for today, Dr. Jaideep Tang sir. He is President FOGSI, Chair YJA Committee OFOC. He is a project lead of FOGSI and USAID project, Secretary General FOGSI from 2018 to 2021. Sir has been awarded the FRCOG Honoria Causa by the RCOG. He's been the past president of MOGS, immediate past deputy secretary AOFOC, immediate past chair FIGO Safe Abortion, past chair of publication and newsletter committee AOFOC, past chair of reproductive endocrinology and infertility committee AOFOC, and past chair of MTP committee FOGSI. Sir is a consultant at Ashwini Maternity and Surgical Hospital, Center for Endoscopy and IVF in Mumbai. He is an independent director on the board of API Holdings PharmEasy, which is India's biggest e-pharmacy. Sir has been instrumental in drafting proposal for FIGO, which has resulted in a grant of $13 million. And he was the technical lead for the project. He is also working on a project with MOGS on assisting underprivileged women in urban slums with their menstrual hygiene needs. He has contributed a lot to FOGSI for the ART bill, hysterectomy rate, cesarean rate, surrogacy bill, PCPNDT, the oxytocin case. I welcome sir and I request him to address this august audience.
Thank you
Jaideep
very
sir.
much. Thank you very much, Pradnya, for that very kind introduction. I hope I'm audible.
Yes.
Yes sir.
It's a pleasure and a privilege to be here at the second episode of the Clinical Pearls of JOGI. Let me congratulate the journal led by our Secretary General and Editor-in-Chief, Dr. Madhuri Patel, for this wonderful initiative, and also the initiative of opening up the design for the cover of the journal. I think that's a very good idea. It will help us to bring the journal closer to members and encourage more members to participate in journal activities. And also for this great idea of having authors present their work to our members. I'm sure this will become an important resource for our members and a sought after slot for those who publish in the journal, again encouraging higher participation in the journal. Let me congratulate Dr. Patel again. I know that she is extraordinarily busy wearing the hat of Secretary General as well as editor, and she always makes sure that things happen on time and very well. Let me also acknowledge Pradnya Supe and Pradnya Chengade and Gaurav and everyone else who works in the journal, along with the chairpersons, Dr. Arun Nayak, Dr. Mala, Dr. Sushil Chawla, and the speakers, Dr. Mahesh and Dr. Maitri. And of course, it's a privilege to share the forum with Chief Guest, Dr. Nandita Palshetkar, whom I had the pleasure of working with as Secretary, both when she was MOGS as well as FOGSI President. And of course, Suvarna, the editor emeritus, again, someone I've had the pleasure and privilege of working with for so many years. So congratulations again, Dr. Patel. I know that this will be a very successful series. And as I said, encourage more participation in journal activities. Thank you very much for having me.
Thank you, Dr. Jaideep, for your kind and generous words. Thank you.
Thank you so much, sir, for always guiding and inspiring us. We have another chief guest with us, Dr. Nandita Palshetkar, madam. She is a director of 9 Bloom IVF centers. She has more than 25 years of experience in IVF practice. She's treated thousands of couples. She's a pioneer in the field of infertility in the last 3 decades and has introduced various technologies for the first time in our country, which include assisted laser hatching, IMSI, embryo spoke, and egg banking. Her IVF centers are in Lilavati. Yes, ma'am.
Thank you. Thank you. I think this audience knows us very well. Thank you so much.
Yes, ma'am. So, of course, madam has been the president of FOGSI. She's been the president of MOGS. She's been the president of Indian Society of Assisted Reproduction, president of IAG. She has various awards to her credit, numerous chapters, talks, and she's also working with police families to uplift their health. And she's the ambassador with the underprivileged girls. Welcome, ma'am, and I request you to please give us few words of wisdom.
Maria, can you take off this CV so I can see the people, please?
Yeah, please stop sharing, Maria.
Yeah, thank you. At the onset, first, I'd like to really address the president of FOGSI, Dr. Jaideep Tank, Dr. Suvarna Khadilkar, who is my guest of honor, and of course the editor-in-chief Madhuri Patel. I think Madhuri has done a wonderful job, and we know that, when, as Jaideep said, when she's at the helm, everything works on time and everything is done very efficiently. And of course the journal team, Arun Nayak, my friend Sujata Dalvi, Anhaita, Pradnya Changade, Supe, Gaurav Desai, and the speakers today, Mahesh and Maitri. I think I can see everybody, all those people who are my friends, so I'm not going to name all of them. But what we need to really appreciate is this clinical pearls of JOGI. It is a culmination of all the hard work, all the, all the effort that one puts in. And these kind of research articles, I think eventually the journal and all these articles actually contribute to a kind of a progress which we have in women's health. How we change our practices, how we can do better. And these journals are very, very important. And I think, as Jaideep said, to encourage people, this is a beautiful way of doing it, awarding prizes and getting them to speak about their work. Because what happens is, this is like a journal club meeting, but of course the prize winners are the ones who deserve to be appreciated. And this form of appreciation which our Jogi has taken is fantastic. And of course Jogi has come a long way. You have got a fabulous, now you've got it, I think, on PubMed and other resources where we can access it internationally. And a lot of people want to also publish their research. So I want to tell you that today what we're doing is we are witnessing the culmination actually of years of research and innovation which FOGSI and Jogi have really brought forward. And we rest on the laurels, of course, of our past editors who have done a fantastic job. And we all know that women's health is very pivotal in our country, especially where women health is not given a priority. In families, I think women put themselves last. So in order to further this progress in women's health, the journal is a very important part. So I want to just congratulate everybody and the prize winners, especially on their outstanding achievements. And please continue to inspire us with your work. I think it's very inspirational what people take the trouble and publish articles. So I think probably you can put them out in the journal, dedicate a page to them. These are the ones who are winners. So we will we'll encourage more people to come. So thank you once again, Madhuri, for inviting me here. I think I'm really happy to be here. And it's always a pleasure that the year is going so well under the leadership of Jaideep. So Jaideep, congratulations on a fantastic term. Thank you. Thank you very much.
Thank you, Nandita. Thank you.
So thank you, madam, for the encouraging words. And this program has been the brainchild of our editor-in-chief, Dr. Madhuri Patel, madam. She has given the authors the opportunity to present it in the form of a webinar where people can actually take inspiration from and present similar good papers. So thank you, madam. And I would also like to invite our guest of honor, Dr. Suvarna Khadilkar, madam. Madam is the president of MOGS. She is a professor and head Department of Obstetrics and Gynecology at Bombay Hospital in Mumbai. She is a deputy secretary general of FOGSI, vice president, and she has been the vice president and secretary of MOGS, editor emeritus, Journal of Obstetrics of Gynecology of India. And she has been the editor-in-chief of JOGI, treasurer FOGSI in 2018-21, president Indian Menopause Society, president. Yes, ma'am. So the list is large, ma'am. Welcome, ma'am. And I request you to please say a few words for us.
Thank you so much. I saw Jaideep leaving just now, but I acknowledge the presence of our dear president, Dr. Jaideep Tang, who has graced this occasion. I congratulate Madhuri for having this wonderful concept of clinical pulse of Jogi, because I find that there was, as an editor-in-chief, I really found that there is some kind of disconnect between the readers and the authors, and there is a limitation of words whenever you write something. But there are so many more thoughts other than what you have already written down, penned down in the, in the article that you have published. Because there are, I myself have written so many articles, but I have always been asked to cut down on the word limits. So there are so many thoughts which just go unexpressed or unwritten. So I think this is the best platform for the authors to even give more than what is already published in their article as to why they thought of doing this study and how it is going to help the public at large or women's health. I think all this is very, very important. I congratulate Madhuri Patel for this. And what wonderful message Dr. Nandita gave just now. I think it is really nice to hear from her always. She's my dear friend since JG days. And so is Dr. Madhuri Patel. And we have Pradnya's, I think Pradnya square is the equation of our Jogi. They're always there together. So all of you are doing wonderful job. And I find that when there are, free papers being presented in the conferences, they're usually kept in the morning hours, 8 o'clock, where, there are a lot of work being done. And when they're presenting, there are hardly about 8 or 10 people in the audience, and those also who are gathered to present their own work. So and Madhuri, you have given a very good platform to these people who have already published. Their work has been valued and verified and agreed upon by expert peer reviewers of the journal. So that is a fantastic thing for today's audience to know that this work has been very, I must say, rigorously scrutinized by our reviewers and then accepted. And then when we selected few of them, which were worthy of getting the awards, have been chosen today for the presentation. So now I think after they present, the readers and the editors and all the audience today can ask their queries about the papers and sort their, any issues they have or any they have in their practice, they can definitely ask. And both the topics which they have chosen are really very, very important. Maternal health, and I think the other one is stillbirths. Am I right? The maternal impact on the fetal health. So I think both the authors have chosen very good topic to publish, and I wish them also all the best for their future, writing career. And I also wish Madhuri and the entire Jogi team all the very best. And this is the first time ever Jogi has taken a activity like this. And I really appreciate from bottom of my heart that the journal is now getting a good audience. And the papers, maybe the article may not have been read so widely, but today it will be definitely heard very widely. I can see already 50 people are logged in. So 50 people, and who all are so deeply interested in research, are here. So I'm sure they will get a very good feedback about their own write-ups. And I wish them both all the best and all of you all the very best. And I once again thank Madhuri for inviting me here as a guest of honor. Thank you so much.
Thank you, Sevana. Thank you for your kind words. Nandita and Jaideep, thank you very much for joining and gracing the occasion and giving your insight to the delegates as well as the authors. Thank you very much.
So thank you, Chief Guests and Guests of Honor, for the enlightening words. So now I request Dr. Gaurav to proceed with the next session, which is inviting our chairpersons for the session. Dr. Gaurav.
Yeah, thank you so much. So we have for the session on these two distinguished speakers, we have an even more distinguished chairpersons. The first is Dr. Arun Nayak, sir. As you all might know, he is a professor and the head of department of LTMG and Sion Hospital in Mumbai. He is also the past president of the Mumbai Society, as well as the secretary of the Maharashtra Society, and also an assistant editor at the FOGSI journal. Sir has a distinguished career with a number of awards and, of course, work in surgical gynecology. Can we have the next chairperson, please, the CV? Next, we have Surgeon Commodore Dr. Sushil Chawla. He has served in the Indian Navy and is a consultant and head of department at INHS Ashwini. He has a number of medals to his honor, and his interests include new teaching learning methods, qualitative research, and PCOS in the young. And last but not the least, we have Dr. Mala Srivastava. I know her very well because she's a very popular gynec-oncologist who practices at Sir Gangaram Hospital in Delhi. And we've met at AICOGs and FOGSI events in the past. Madam also has a vast number of awards and accolades to herself. I think there are too many to mention, but she's a very hard worker with the organization in Delhi. And chairpersons, it's good to have you here. Could I request the chairpersons to introduce the speaker?
Yeah, thanks. Thanks, Gaurav. May I request Dr. Chawla to introduce the first speaker?
Yeah, good evening, everybody. Only one thing. Pearls do not always come from Hyderabad. Sometimes they come from all over the country. And we have one of the pearls coming in form of Dr. Mahesh Asalkar, who will be presenting his article on COVID, pneumonia, and maternal mortality. He is a alumnus from St. GS Medical College and KM Hospital, Mumbai, who passed his DNB also experience, and he completed his diploma in bioethics from IGNU. He has special interest in teaching and research aspect. Now, I'll not come in between Dr. Mahesh and his presentation. I invite Dr. Mahesh to share screen and continue his presentation. Dr. Mahesh, the stage is yours.
Yes, thank you. Am I audible?
Yes, Dr. Mahesh.
Yeah, just a moment. I'll share my screen. Some issues there. Yeah. First, let me thank Dr. Madhuri Patel, Editor-in-Chief, the FOGSI President, and all other dignitaries of FOGSI and chairpersons for giving me such an opportunity to present myself and our work in front of intellectual audience. Otherwise, generally, our audience is our residents and our platform is our maternity and gynec ward. That is our routine. But here, I'm really glad to present my work in front of the intellectual audience. I begin with my presentation. Yeah. So my topic of presentation is prevalence of maternal mortality and clinical course of maternal deaths in COVID-19 pneumonia, a cross-sectional study. I myself is a first author. Dr. Smita Thakkarwad, Associate Professor working in our institute, and Dr. Ilaf Rumani and Dr. Nitika Sharma, they are the senior residents from our institute. Before I begin with my presentation, I would like to tell about the article and the institute where this study was conducted. This is the original research work which was published in the Journal of Obstetrics and Gynecology of India in May-June 2022. This article has got 19 citations till date. We also received the best paper published in JOGI second prize in 2022. The entire research was conducted at Postgraduate Institute and Vysim Hospital, which is run by Pimpri-Chinchwad Municipal Corporation. We have 750 beds in the hospital, out of which 220 beds are maternity beds. During the COVID pandemic, the inter-bed distance was supposed to be increased, so we reduced the beds to 150 maternity beds during the pandemic. And it was designated by the government as a tertiary care facility for maternity care for COVID-positive pregnant patients. In the beginning, this conflict of interest, actually I'm waiting since last 10 years to write few sentences on this slide, but unfortunately I'm unlucky to write a single sentence because I did not receive any grant up till now. So there is no conflict to declare regarding this study. Every one of us know that on March 11, 2020, WHO had officially announced COVID-19 had become a global pandemic. And at that time, most of the studies were on the general population, and there was insufficient data regarding effect of COVID-19 in pregnancy, and the available literature on COVID-19 infection in pregnancy was insufficient. What we were knowing from our general knowledge, that pregnant women are more susceptible to acquire respiratory viral infections due to physiological changes in the immune and cardiopulmonary systems during pregnancy. During pregnancy, there are alterations in the cellular immunity, especially in the second and third trimester, that is generally thought to protect the fetus from rejection by the mother. These changes in the cellular immunity can predispose the pregnant women to infection with certain pathogens such as viruses, fungi, tuberculosis, etc. These physiological changes are in the immune system, such as reduced lymphocyte proliferative response, diminished cell-mediated cytotoxicity, reduced number of helper T cells, reduced lymphokine response to alloantigens, and hormonal changes which are happening in the body are increased levels of progesterone, human chorionic gonadotropin, alpha-fetoprotein, and cortisol. This inhibits the cell-mediated immune function. Physiological changes include increase in the oxygen consumption, elevation of diaphragm, decrease in functional residual capacity. Aspiration is more common or can happen during labor, which aggravates the airway obstruction. And all these changes makes less tolerable even a brief period of hypoxia in the third trimester. These pregnant women are not able to tolerate. So the aim of our study was to audit the maternal mortality due to COVID-19 infection. Our objectives, the primary objective was to estimate the prevalence of maternal mortality due to COVID-19 infection in obstetric patients. Secondary objective was to systematically study and analyze the clinical course of infection in mothers who had mortality due to COVID-19 pneumonia. Coming to the methodology, this was a prospective, single-centered, cross-sectional study, which was done from 1st May 2020 to 30th April 2021. That was a 12 months, and this corresponds with the first wave of COVID pandemic. It was done at Postgraduate Institute and YCM Hospital. The study population included 871 pregnant women. The inclusion criteria for the study was all obstetric patients, that is antepartum, intrapartum, postpartum, up to 6 weeks, having COVID-19 infection, which was detected by RT-PCR or rapid antigen test. Data was collected in uniform, consistent, and reliable manner by trained qualified doctors with the use of standard pro forma. Key variables which are mentioned in the data collection tool, which we will be seeing in the next slide. The statistical analysis was done by using IPINFO software. The critical cases which had a maternal mortality were further analyzed. Institutional Ethics Committee approval was obtained, and the confidentiality of the data was maintained throughout the study. This is the data collection tool. Various parameters such as demographic data, which included age, body mass index, socioeconomic status, these were collected. Clinical presentation and need for ICU with duration, symptomatology on admission, oxygen saturation at presentation, duration of hospitalization or ICU stay, admission to the death interval was noted, obstetric history, medical history, including the history of any comorbidities. Lab investigations included CRP, full blood count, neutrophil to lymphocyte ratio, D-dimer, LDH, ferritin, ESR, and fibrinogen. Especially the neutrophil to lymphocyte ratio was very significant, especially in COVID pneumonia, this ratio was increased. In fact, when we were serially monitoring the counts of these patients, we were looking into the neutrophil to lymphocyte ratio, and those patients where this neutrophil to lymphocyte ratio was persistently high, these patients had severe complications, including the maternal mortality. We will discuss this at the time of discussion, but this was one of the significant findings. Chest X-ray was done serially as per the need. Treatment was given as per the guidelines given by the ICMR or government of India, and it was very streamlined treatment by the National Task Force. We were just executing those guidelines, and the maternal outcome was measured as a stable discharge or died. So what we were knowing when the pandemic started, the initial literature showed that there was a brief systematic review by Marcos. It mentioned that in 6 countries, there were maternal deaths by July 1, 2020. It included 6 countries, out of which 3 were high-income countries like France, UK, and United States, and 3 countries were middle-income countries like Brazil, Iran, and Mexico. Total number of maternal deaths recorded by that time were 160, and out of which there were only 22 maternal deaths from high-income countries, while middle-income countries were 138 deaths. So out of 138, 124 were from Brazil, representing 77.5% of all maternal deaths reported in the literature. So what could be the situation in the lower income countries, or what could be the situation in our country? What is the situation in our institute, in our area? That were the questions in our mind. So we studied 871 pregnant women affected with COVID-19 infection at dedicated COVID hospital, and we reported 9 maternal deaths in our study. At that time, there was a preprint or unpeer-reviewed data from 2 registries. One was a pan-COVID registry, which was from UK, and they reported 3 maternal deaths out of 651 patients, giving the prevalence of 0.46%. And there was another registry, Apsonum registry, which reported 5 maternal deaths out of 2,398. That is 0.21% prevalence. In our study, we had higher prevalence compared to the prevalence mentioned in these 2 registries. However, their inclusion criteria were little different, especially with the second registry. They included 2 weeks prior and I think till postpartum or something like that, but their inclusion criteria was little different. So these were our results. So total COVID positive obstetric patients were 871, and total number of maternal mortalities were 9. Prevalence of maternal mortality due to COVID infection was 1.03. There is some problem with the presentation. The next slide.
Must have got freeze, sir. Try it.
Yes, there is little technical difficulty. It's not moving. We'll wait for a minute.
Sir, you can reshare the slides. You can stop sharing and then again reshare.
Okay, okay.
Yeah, now we can view, sir.
Yes. So these were our results. The prevalence was 1.03% in our study. And these were the salient features of our results. Cases with maternal mortality were mostly from the 3rd trimester. That is 5 cases out of 9 cases were in the 3rd trimester. Cases presented with moderate to severe illness with breathlessness and myalgia. In all 9 cases, this was a prominent feature, breathlessness and myalgia. Cough and fever was noted in 7 out of 9 cases. Tachypnea was present in all patients. Saturation below 90 was seen in 6 cases, below 94 in 3 cases. Chest X-ray showed bilateral lung affection in all 9 cases. So bilateral lung affection, when these patients had, leukocytosis with raised neutrophil to lymphocyte ratio was predominantly seen. Thrombocytopenia was noted in 5 cases. Elevated levels of acute phase reactants and inflammatory markers such as CRP, serum ferritin, ESR, LDH, D-dimer, and serum fibrinogen was observed. So this table shows the socio-demographic parameters such as age and gestational age at admission. Out of 871 patients, most of our patients, that is 54% patients, were in the 20-25 age group. And least number of patients were, that is 14% from the more than 30 years of age group. However, if you see the mortality, it was more when the maternal age is more than 30. That is contributing to around 55.56%. There were out of 9, 5 deaths were in that particular age group, while other 2 groups had only 2 maternal mortality each. That is 22.22%. Gestational age at admission, maximum number of admissions were there in the more than 28 age group, 28 weeks of gestation, that is 58%. And again, the maternal mortality was high in 3rd trimester, while 1st trimester and 2nd trimester, the admission rate was also less, that is 11% and 31% respectively. And there were 2 maternal mortality in 1st trimester and 2nd trimester. So earlier it was actually not very clear whether the pregnancy is a risk factor for severe illness from COVID-19, but there was, as the pandemic was growing, there was a growing evidence that pregnant women, especially in the third trimester, they are at risk of severe illness from COVID-19. Another author, Hazari et al., he has reported 7 critically ill patients, and out of 7 critically ill patients, 5 cases were from the third trimester. And another study, UK OSS study, that is United Kingdom Obstetric Surveillance System, in that study also most of the women were hospitalized in the third trimester or peripartum. This slide shows body mass index and the socioeconomic status. In our study, most of the patients who had mortality were having normal BMI. But however, the admission rate was also very high in this particular age group. Admission rate was 66%, and there were 6 mortalities. And overweight category, there were 19%, and there were 2 mortalities. Most of our patients were from middle socioeconomic class. We have also noted the time from the onset of symptoms till hospitalization. That is the time taken by the patient to report to the health system or seeking time required to seek the health care. So those patients who reported within 3 days, in that particular group, there were 38% of patients, and there were 2 mortalities out of 9 mortalities. Those patients presented between 4 and 5 days after their onset of symptoms. The percentage of patients was 42%, and there were 3 deaths in that group. However, those presented after 5 days, there were such only 20% of patients and 4 maternal mortalities in that particular group out of 9 maternal mortalities. Then severity of infection at the time of admission. Asymptomatic patients were maximum in the first wave. However, when this is not a part in second wave, the symptomatic category was more, and this particular study is related to the first wave, where maximum patients were asymptomatic, 53%, mild cases were 36%, moderate were 8%, and severe were 3% admissions. However, whatever the mortality we noted, where in the moderate category there were 3 deaths, and severe category there were 6 deaths, contributing to 33% and 66% respectively. The same what we have seen, age, individual case-wise distribution, age, body mass index, socioeconomic status, we have seen the gestational age, we have seen, and there were associated high risk factors in which anemia was the most common, and other factors were twin pregnancy. This case 9 was a case of ruptured ectopic pregnancy, and she required exploratory laparotomy. However, she had bilateral COVID pneumonia. These were the symptoms in which dyspnea and myalgia was reported in all 9 patients, and other symptoms such as cough, fever, sore throat, and less common symptoms were anosmia, loss of taste, headache, and diarrhea. We have also inquired about, is there any other family member which is infected in the family? And all 9 patients had at least one family member affected. In a cohort study which was conducted by Jose Wheeler, they found the presence of any COVID symptom was associated with the increased morbidity and mortality. So if the asymptomatic patient is there, less likely there will be further complications or mortality. But if any symptom is associated, there is a chance that the patient may have complication. Specifically, severe pregnancy and neonatal complication rates were highest in women if fever and shortness of breath were present, reflecting systemic disease. Their presence for 1 to 4 days was associated with severe maternal and neonatal complication. These findings correspond with our study, suggesting that presence of any symptom of COVID-19 increases the morbidity and mortality compared to asymptomatic infection with this COVID virus. COVID-19 affection among the family members of the disease, all 9 patients had at least one family member affected. However, there was no mortality in the family members. That suggested that pregnancy, it could be a high risk factor for poor outcome. Other parameters such as SpO2 on admission, respiratory rate on admission, need for oxygen, ICU and HDU requirement. More than 95%, there were all patients had a saturation below 95. 90 to 94, there were 3 cases out of 9. 85 to 90, there were 2 cases. 80 to 84, there were 2 cases, and less than 80, there were 2 cases out of 9 cases which had mortality. Respiratory rate was 21 to 30 in 5 cases and 31 to 40 in 4 cases. So tachypnea was very predominant. Once you see these patients on admission, the tachypnea was predominant in these patients. And all 9 patients required oxygen right from the beginning, and ICU and HDU requirement was there for all 9 patients. Admission to death interval, within 2 days, there were 3 deaths. 3 to 5 days, there was 1 death. 5 to 9, there were 3 deaths, and more than 10 days, there were 2 deaths. Obstetric intervention was not done in 5 cases, while cesarean section was performed in 3 cases, and exploratory laparotomy was done in 1 case. Indication for surgical intervention, that is LSCS, was done in 3, and exploratory laparotomy was done in 1 case, and 5 cases did not require any surgical intervention. Vaccination status, all 9 patients were not vaccinated. Actually, the vaccination for pregnant women, by when the study was going on, till that time, it was not recommended for the pregnant women. This is an investigation chart. This investigation chart shows the WBC count was abnormal in 8 patients, platelet count was abnormal in 5 patients, neutrophil to lymphocyte ratio was abnormal in 9 patients, CRP was abnormal in all 9 patients, LDH was deranged in 7 patients, D-dimer was abnormal in 7 patients, ferritin was abnormal in 9 patients, and fibrinogen was abnormal in 5 patients. These were the X-rays. We can see that this is case 1, 2, 3. All patients had bilateral affection. So bilateral affection of the lung in severe cases was noted. Before going to the discussion, if there are any questions up till now, I can take few questions, then I can proceed, because there is a little repetition of the results and then associated discussions. So few slides will be repeated. If there are questions, I can take the questions.
I think Dr. Mahesh will finish the discussion and then we'll keep time for the question and
Yes, no problem, doctor, no problem. We have discussed that on March 11 March 2022, WHO has announced COVID pandemic, and it was highly important to systematically investigate the clinical characteristics and outcomes of pregnant women with COVID-19 to provide strong guidelines for prevention, treatment, and management. Earlier in the COVID-19 pandemic, it was not very clear whether the pregnancy is a risk factor for a severe illness from COVID-19. But there was a growing evidence, and especially the 3rd trimester, the patients can have affection, can have complication. This review by systematic review by Marcos, we have discussed from 6 countries that has already been discussed. Then the 2 registries, that PAN COVID registry and Absalom registry, we have discussed. The pan-COVID registry recorded suspected or confirmed COVID-19 cases at any stage in the pregnancy. This was in UK and 10 other countries, and the other registry has reported maternal COVID-19 cases around the time of birth, from 14 days before and 3 days after the birth. In our study, we have included antenatal, intrapartum, postpartum up to 6 weeks. So maternal mortality was uncommon in both registries. Only 3 deaths occurred out of 651 cases in pan-COVID registry, and this other registry was 0.21%. So our prevalence of maternal mortality was 1.03. We had higher prevalence of 1.03% as compared to the prevalence mentioned in the other 2 registries. Out of these 9 cases, 5 cases were in the age group above 30, while between 25 to 30, there were 2 cases in each group. BMI was normal in 6 cases, that is case number 1, 3, 5, 6, 7, and 9, while it was more in 2 cases, case number 2 and 8, and 1 case had BMI less than normal. There is another systematic review where they mentioned that most of the pregnant women, that is almost 74% of women, were asymptomatic, and this systematic review included 64,000 pregnant women worldwide with suspected or confirmed COVID-19 cases. There was another study from USA which reported that 86% of women were asymptomatic. Most symptomatic women were experienced only mild or moderate or cold flu-like symptoms. In this review, the most common symptoms of COVID-19, which were COVID-19, were Cough was seen in 41% of patients, fever in 40% of patients. Less frequent symptoms were dyspnea, myalgia, loss of taste, and diarrhea. However, in our case, dyspnea was prominent and myalgia was prominent. That was a feature in our study. Pregnant women with COVID-19 were less likely to have fever or myalgia than non-pregnant women of the same age. That was mentioned in the literature. So in our study, we noted that all 9 cases were symptomatic at the time of presentation. Breathlessness and myalgia was present in all 9 cases, while cough and fever was noted in 7 out of 9 patients. 2 patients in our series had loss of taste and smell. However, breathlessness and myalgia was predominant feature in these 2 cases. In a cohort study by Joe Wheeler, they found that presence of any symptom is associated with increased mortality and morbidity. Specifically, severe pregnancy and neonatal complication rates were high in women if the fever and shortness of breath was present, reflecting systemic disease. The presence for 1 to 4 days was associated with severe maternal and neonatal complications. These findings correspond with our study, suggesting that presence of any symptom of COVID-19 increases morbidity and mortality compared with asymptomatic infection due to the COVID virus. Out of 9 cases, 5 cases were in the 3rd trimester. Pregnancy, especially in the 3rd trimester, may be a high risk factor for poor maternal outcome in COVID-19 infection. Out of 5 cases in the 3rd trimester, 3 cases, that is case 2, 4, and 8, were delivered by cesarean section, and 2 cases, that is case 1 and 3, and were preterm. Decision for termination of pregnancy is challenging, and that is mainly due to the prematurity. And in few cases, conservative management was preferred with the hope of better maternal outcome with COVID treatment as per the guidelines. However, patients had a mortality in due course of time. In UK obstetric surveillance system, most women were hospitalized in the 3rd trimester or peripartum, bearing in mind that admission at the term to give birth will contribute to this distribution. Most of the admissions in the initial period of pandemic were because the patients were getting screened for COVID, and once the screen is positive, even the isolation was, they were hospitalized for the isolation purpose. Later on, the home isolation started. So this category of asymptomatic was mainly getting home isolation. The other author, Hazari et al., in the study of critically ill patients, mentioned that 5 cases out of 7 patients are in the 3rd trimester. We have also discussed which physiological changes like elevation of the diaphragm, decrease in functional residual capacity, increase in oxygen consumption, increase in lung water. These all physiological changes, they increase the susceptibility of the mothers for the infection. We have noted admission to death interval, which was less than 72 hours in 3 cases, 72 hours to 1 week in 1 case, 1 to 2 weeks in 4 cases, and more than 2 weeks in 1 case. Clinical disease severity was moderate in 3 cases and severe in 6 cases. Neonatal outcome was good, and babies were negative for COVID-19 and they were discharged. We also inquired about COVID-19 infection in the family members that we have discussed, and none of the family members were affected, but there was no mortality. This suggests the bad outcome may be due to the pregnancy itself. Obstetric management of this COVID-19 patient was challenging, especially in the 3rd trimester. We had 5 cases, gestational age between 33 and 39 weeks, and decision of delivery by LSCS was taken in 3 cases out of 5 cases for fetal indication, while 2 cases require conservative management as per COVID treatment guidelines. The management was continued. In patients delivered by cesarean section, the neonatal outcome was good. All cases were managed by the multidisciplinary team involving intensivist, pulmonologists, anesthesiologists, and physiotherapists. For pregnant women in the 3rd trimester who had COVID-19 infection, an individualized assessment is required, especially with the multidisciplinary team, to decide whether emergency cesarean birth or induction of labor should be prioritized, either to facilitate maternal resuscitation, including the need for prone position, or because concerns regarding the fetal head. So even the delivery can be planned for the maternal indication also, but for that it requires the multidisciplinary team. So we have discussed about the all inflammatory markers. Our study has shown that these inflammatory markers, especially N/L ratio, was more than 3.5 in 100% of cases. LDH levels were raised in 78% of patients. The major coagulation indices like D-dimer, fibrinogen levels were elevated in 78% and 56% patients respectively. The values were more than 3 times the upper limit of D-dimer in 67% of patients, which is similar to study by this particular author. Liu F. et al. Found that patients with CRP more than 41.8 were more likely to develop severe disease, which was reflected in our study also. Several other studies has also cited significantly higher values of these coagulation indices in critically ill patients. As far as vaccination of these patients are concerned, in our study, there were no vaccines. And when this study was concluded, and in the same month, 2 vaccines, Covishield and Covaxin, were available for use in India under vaccination program. However, use of vaccine was mainly restricted to senior citizens in the initial phase, followed by adults more than 18 years of age group. However, it was not recommended for use in pregnancy till that time. The Joint Committee on Vaccination and Immunization have updated their guidelines on 16th April 2021, and they recommended that the vaccine can be given to the pregnant women also. There is no reason to think that the vaccines will not protect pregnant women effectively against COVID-19. As the COVID-19 vaccines have not been tested in the pregnant women, we cannot say for sure that the vaccine will have worse side effects in pregnant women. Although there is limited UK data regarding COVID-19 vaccination in pregnancy, there was a credible real-world data from United States where around 90,000 pregnant women were vaccinated, mainly with mRNA vaccines such as Pfizer, Moderna, etc. And there were no safety concerns. There were no safety issues which were reported. Coming to the conclusion, COVID-19 pneumonia is an additional toll for maternal mortality, which needs to be considered in future, and it is an indirect cause along with other causes of maternal mortality. The risk factors for poor outcome were second and third trimester of patients affected with COVID-19, late presentation to the hospital, moderate to severe disease, raised inflammatory markers such as neutrophil to lymphocyte ratio, CRP, ferritin, D-dimer, etc., and bilateral lung affection. These were the factors for the poor outcome. Cautious attitude is required even if the patient is asymptomatic or mild infection. These patients require surveillance. Stringent protocol and national or international guidelines need to be followed. MDT approach is required, including the obstetrician, physician, intensivist, anesthesiologist, and physiotherapist. Special registries, nationwide or institute-wise data is to be maintained, and maternal audit of COVID-19 infection is to be done. This we have discussed. Joint Committee on Vaccination has recommended this vaccine for the pregnant women also. Coming to the strength and weaknesses of our study, the strength of our study is rigorous approach in collecting primary source data from the hospital and documenting maternal deaths related to the COVID-19. Our study has demonstrated that COVID-19 related maternal mortality is not zero. There is a mortality in COVID-19. Weakness of our study, our data was preliminary at that time, and it was mainly pertaining to the first wave of COVID pandemic. The current mortality in our study represents the scenario before COVID vaccine was introduced for pregnant women. This data is from a single center and represents virulence of regionally involved strains. As no mutation data is available, these results may differ due to difference in the virulence across the globe. Case fatality rate, attributable risk, relative risk of maternal mortality by COVID, we could not calculate because that will require a cohort study. We acknowledge the faculty from radiology and pathology department for providing necessary inputs for our study. Our sincere gratitude goes to all supervisors, data collectors, A&M, study participants with their family members for their cooperation and support. These were our references. Thank you for the patient listening.
Thank you. Thank you, Dr. Mahesh, for that detailed presentation of your study. I just would like to tell all that your paper had come to me for review, and I found that those were the dates where a lot of questions we were struggling to find the answers. And you rightly mentioned that government and ICMR guidelines were very useful to us. I work at Sion Hospital, which was not a government recognized COVID hospital, But during the first stage of COVID, we still found so many patients coming to us, and we had to convert our hospital. We had to shut down our routine work and then start admitting those COVID positive patients in our wards.
Yes.
But fortunately, most of our COVID positive patients were asymptomatic or mild during the first wave, and we delivered almost 100 cases. Those were the days where there was a lot of those days were gloomy days, and not a lot of information was available. What would be the effect on maternal health? What would be the effect on the baby? And I still remember when we presented our data, about 100 cases who had good outcome, and the babies were almost spared from getting COVID infection. And that paper had received a lot of publicity in electronic media as well as newspapers. And I think we continued our study, and later on during the second wave also we started getting more serious cases. And like your study has found, those patients who presented to us with severe symptoms, we also had mortalities in those cases which presented later on during the second wave of the COVID. I think we can have some question answers from the audience and then other experts who are attending today's CME. So Dr. Madhuri, thank you for this very wonderful initiative and your comments.
Yeah, excellent, Dr. Mahesh. And I'm also talking about Arun, who has experience of very large hospital, Sion Hospital, where almost 10 to 12,000 deliveries are occurring over there. And Dr. Mahesh, I'm also impressed. And you know what Dr. Arun has said is right, that he was one of the reviewer, that today is committing that. And you know, it was an excellent paper. When there is an award-winning paper, we really look into all aspects, not only the data, but how it was studied, what ideas, everything we talk about, we should talk very well. Now I will ask Dr. Mahesh that you had a 9 patient who died because of the COVID-19,
Yes.
the pneumonia. Were there any survivor of the pneumonia because of the COVID infection?
Yes, there were lots of survivals. Actually, this is the tip of the iceberg which we presented, but there were many patients actually, because the paper was pertaining to the mortality. I presented that particular data, but our outcome was really good for this. I will not have figures currently regarding that, but even moderate and severe cases, we had a very good, because we were working totally in the COVID. Even last week, I had one COVID patient. In between, we are getting such COVID patients now also, but not very rare nowadays.
So this was a retrospective study, right?
No, this was a prospectively data collected, because in the beginning only we planned that, okay, we are now going to manage the COVID, let us document. I said that in the beginning, there is no conflict of interest. We did not receive any funds, but what I feel that it is the documentation of your work that is very, very important. Keen observation and documentation. These are the two things, and it will give us publication from a very simple topic. Also, we'll get good results. That is what I feel. And this work was means our hospital was designated as a COVID hospital, so we were supposed to do. So let us do in a better way, best way, what we can do. So that is how we started.
Okay, now second question of mine is that it was the first wave where you had these problems of maternal mortality due to pneumonia. Was there any particular treatment was done for this patient?
Yes, actually,
because those days we were not knowing the treatment.
What is exactly the treatment is, even the guidelines were coming and we were executing the guidelines. But in between, the plasma therapy came. We instituted plasma therapy also. The plasma therapy also gave result. Then Remdesivir came. Remdesivir was used, and the results were good with whatever the affection. But whatever the treatment was given, most patients, almost I'll say that these mortalities are very minimal compared to the total number of admissions. And even moderate and severe cases, we had very good outcomes. But once the Remdesivir came, after that the result was quite good. Patient responded very well. Yeah.
Okay, great presentation.
Yes, I think Maruti.
comment?
Yeah, Madhuri, can I just add here? Like Dr. Mahesh said, there were guidelines which were coming regularly from ICMR, and they had categorized cases into mild, moderate, and severe, and the guidelines were crystal clear. they had different parameters on which the treatment protocols was supposed to be administered. And I think most of the hospitals were following those guidelines.
Yes, that was one of the best thing.
Yes. And
Because
that is
even
why there
we
was
were not knowing,
uniformity.
just follow the guidelines, just follow the guidelines.
Exactly. And I think there was uniformity in managing these COVID positive patients all over the country because of these guidelines.
True. And there were jumbo facilities. They were managing the general patients, and especially for maternity, we were getting any referrals from other hospitals also. So that jumbo facility has also worked very well for the community. We could manage well. All of in the government system, we could do well. Yeah.
Even I was attending the MDSR, that is Maternal Death Surveillance and Response in Mumbai district, and we had lost many COVID, maternal mortality, not only because of pneumonia, but other causes which were aggravated, because of the COVID. So that era was really bad, and now we know that what is the reason and what is the thing. So we have really streamlined our management, and secondly, now we all have become immune after the COVID vaccination and all. So we are, at present we are not seeing, even there is a cough or sneezing, we don't do. Those days we used to do even COVID days sneezing. And so very good presentation, Dr. Mahesh, and I would ask the other chairperson to share their experience and comment about the paper.
Excellent paper, Dr. Mahesh. Initially, there was this thought that young patient will have better immunity, and the patients who are more than 50, they will not be able to cope up with the COVID infection. But definitely, pregnancy being an immunocompromised status, they required special care. And the 9 mortalities that you had, was there any difference in the age group? Were there on the higher age group? Do you think that has affected their mortality, or it's the pneumonia which has, or maybe they had come in the later stage, in the advanced stage of pneumonia, that has caused their mortality? They presented late to the institution. That has caused their mortality.
Actually,
what do you think is the
it could be the combination of these 2-3 factors together, because late presentation was one thing, bilateral affection of the lungs was common thing, but we noted that most of the patients were in the age group more than 30. Now, as far as maternity is concerned, especially the public health hospital is concerned, most of the maternity patients are below 30 years of age group in the government hospital, at least. In private sector,
we do
now
get
the
patients who are 35 plus also. So do you think this age could be one of the confounding factor?
Yes, age was
Some
one of
patients,
the influencing factor for the mortality or the severe complications of COVID.
And none of the patients had GDM in these 9 cases. They didn't have any comorbidity.
Not in these mortality cases, but we had definitely GDM in the patients who we manage otherwise. In these 9 patients, there were no GDMs.
Because they presented late, maybe you never had time to investigate whether they were undiagnosed or not.
Maybe.
That could have confounded their mortality as well.
This is one question from the audience, I think, about the challenges. Actually, there were many challenges. Managing the pandemic itself was a big challenge for us. And right from the the hospital itself, we required to have the different facilities for COVID positive patients, for the doctor's entry point, exit point, doning off, and all this was totally new to all of us. But these facilities we created. Not only that, once the patient is negative, we had to create certain wards where the negative patients can be kept, and it is to be managed by some different team which is not managing the COVID patients to avoid the cross infection. So we had that big challenge within the manpower which was allotted to us. And working in the PPT kit was an totally different experience for the residents, and I really appreciate our residents. And one of our residents got affected, and he required ventilator support for 1 month, and we were really worried about his health, but luckily by God's grace he came out and had a very good outcome. So actually, really, residents have also worked very hard in that. Yes.
Guidelines were very important those days.
Yes.
Everybody was sticking to the guidelines, and that really streamlined the management.
True.
And that is one way that we can one example that when we have proper guidelines and everybody sticks to the guideline, the results are good.
Yes.
Excellent paper and excellent observation. I must congratulate Dr. Mahesh for
Thank
your
you.
presentation.
Thank you. Thank you all.
Thank you, Dr. Mahesh. Dr. Sushil Chawla, any comments?
Only one comments. Probably most of you will disagree with my statement. There was one thing which I always followed. We delayed vaccinating our pregnant women. Because I always remember that one Hindi dialogue, हम माँ या बच्चे से एक को बचा सकते हैं. That was not the statement which I think we should have followed. When we were vaccinating everybody, I think pregnant women should have been vaccinated the moment first we knew it is going to be much more severe in pregnancy. Whether what will happen to the baby would have been the secondary concern. If we are losing mothers, I think that dialogue does not come in practical aspects. We have to save the mother. We had to save the mother. Probably most of you will disagree with this statement, but this is what I followed. Even when there was thing, I gave a choice to the mothers. You want, we'll give you the vaccine. Because there was something which I fully agree, sir. They were against the guidelines which were given by the government of India. But it always came to this. If I have to say save. I agree. I fully agree if they were against the guidelines given. But that's what I said. Probably most of you will disagree with my statement here.
May I make a remark here?
No. Dr. Chawla, I am not disagreeing with your statement. What I want to say is maybe those who are attending those policy decision meetings, maybe somebody should have put forward this idea, and then government, if would have accepted that idea, maybe we could have started vaccinating our pregnant women much earlier.
May I make a comment, Dr. Nayak?
Yeah, Nirja.
Very good afternoon.
Good afternoon.
Good afternoon.
And it has been wonderful to hear the presentation of Dr. Mahesh. And I would like to put in a little comment here, because I've been not only that I've been very close to the developments regarding introduction of COVID vaccination for pregnant and lactating mothers, whether it was the FOGSI position statement with IIP and whether it was at NTAGI. And also because this is a teaching forum we are in. This journal forum is being attended by many students. And here we cannot afford to have any dichotomy of thought that they must be encouraged to always follow the guideline. Otherwise, there can be serious medico-legal repercussions for them. Yes. So there is a huge problem when you give anything, and we have seen that to date, people are questioning whether that vaccine with emergency use authorization was the right step or not. So I would not like any students to go away with the idea that they should at all play with the guidelines from government, whether this is this or PCPNDT or anything at all. And secondly, I will say that I think everybody was very much seized and concerned. But unfortunately, the people at the start of the pandemic do pay a price. Not only the pregnant women, but even people with comorbidities were equally in the soup. So FOGSI, I think it was absolutely commendable how fast it acted, how much people worked. And, you know, in spite of being so much stressed by their increased clinical problems, they took out the time, FOGSI, IAP, and within few days, I will say, they produced the document and it went to the higher authorities who fast forwarded it in no time. So it is, in fact, a matter of consideration, and I won't take much time, but I will just say once again to everybody, please do not be swayed by feelings, because eventually those don't hold when things go wrong. When things go right, everybody is happy. When things go wrong, we have seen the pain of litigation. We have seen the pain of assault. And we should always be very, very much judgmental with our heads on our shoulders. That is all I will say here.
Absolutely, Nirja. Thank you very much for clearing the thoughts about vaccination. because even today there are groups, there are comments coming from, there are a lot of people who are anti-vaccine, and these are the people who are still putting their views about vaccine not being good, and then so many complications occurring in the people who have taken the vaccine. So it's a good that you have cleared the air about what was the status of vaccine and why it took so many days for government to come out with the guidelines. And I absolutely agree with your views that if government has issued some guidelines, we should stick to those guidelines. We shouldn't have our personal opinions, and we should not sway away from those guidelines. Otherwise, our career, our practice can come into problem. And I think we should stick to the government guidelines.
Yeah, I would like to say over here what Dr. Nija has said, that the FOGSI, we really work hard to come out with the guidelines, not I will say exactly guidelines, but good clinical practice recommendation. And this is Dr. Alpesh Gandhi and Dr. Jaideep Time as a secretary and Dr. Alpesh Gandhi as a president. We really work hard, entire team, where as Nija has mentioned, and we were forwarded it to the government, and I think that has helped a lot in getting the guidelines during pregnancy. So thank you everybody for this excellent interactive session. We must thank Dr. Mahesh. He presented very well. We have heard Dr. Sushil Chawla also comment. He in the beginning only said whether you agree or don't agree. He has mentioned that, and Nija has cleared about that. So we are very happy, and I think we can go ahead with the second paper. Yeah, congratulations, Dr. Mahesh again.
Thank you. Thank you all.
Okay, continuing with the second presentation, it's coming from Seoul directly. I congratulate Dr. Maitri Parulekar for presenting her topic, Analysis of Maternal Factors. And Dr. Maitri, she is presently on doing her current clinical and research fellow in Gynae at Seoul, Korea. She has written this paper with other faculty members from St. GS Medical College and KEM Hospital. Dr. Maitri, the screen is yours. Please share screen and go ahead with your presentation.
Yes, thank you, sir. Just give me a minute to share the screen. Good evening to all the dignitaries, the chairpersons, respected seniors, and my colleagues. To be frank, it's a little intimidating to be presenting in front
It is
of
not
such
visible.
dignitaries. It's not visible?
The screen is not visible.
No, not yet.
Okay, just a moment. I will try sharing it again. Is it visible now?
No, not yet.
It's showing that it's paused from the
host.
organized, yes.
Maria,
Ma'am, we have
can you
given
make
all
her
the permissions.
co-host? Maria, can you make her co-host?
Ma'am, she is co-host.
Okay. Hey.
Because
Maria, stop sharing. Maitri, have you sent the presentation to us? We can share on that.
Yes, madam, I did.
You have to open it. You have to keep it
Can
open.
Ma'am,
you
should
see it
I
now?
share the presentation? I might have it.
Can
Hello?
you still not see it?
It is not opening. You have to open the presentation, then share.
Maitri,
I did
open
that,
it in
ma'am.
your screen and minimize it. I think you shared it in the beginning, na, Maitri?
Yeah, I did, and it was
So you just open
happening
it
at
and
the time.
minimize it, and then you press share screen. Got it?
Okay, ma'am. Just a second. I'll try that again. Can you see it now?
Yeah, your
On my
presentation
end,
is
it's
not
Ma'am,
open.
actually you are
Your
using Mac
presentation is
machine.
not open.
मैम आप मैक मशीन यूज कर रहे हो, उसका सेटिंग में थोड़े चेंजेस रहते हैं। आपको दो स्क्रीन दिख रहे हैं क्या, एक फुल और एक पॉपअप में छोटा स्क्रीन?
हाँ।
जो छोटा स्क्रीन है उसको आप एक बार मैक्सिमाइज करिए।
किया सर।
उसको शेयर करिए वो स्क्रीन को आप।
I had done the same earlier actually, but
You have to choose the screen which you are sharing. You understand?
yeah, ma'am, I did that somehow, but just a second.
Wait a second.
Presentation, please share your.
I will just share.
Yeah.
I will just try
Okay.
sharing. Can you see my screen, everyone?
Yes, yes, yes.
Yeah, Maitreyi?
Yeah.
I will just press slideshow and then you can start presenting. Okay?
Okay. Good evening, everyone. Thank you for giving me this opportunity to present in front of such respected dignitaries. Ma'am, how do I switch the slides from your end?
Oh yeah, I will change.
You have to say next. You have to say next.
You have to tell me next.
Okay, next slide, please. So today I'll be presenting my research on analysis of maternal factors impacting neonatal near-miss events. It's a tertiary care experience. Next slide, please. Next. So I was one of the co-investigators and the first author of this paper. The principal investigator of this study was Dr. Harshada Thakur. She is the associate professor in the Department of OBGY at CGS Medical College, and Dr. Padmaja Samant Madam, who is the professor and head of department. And I would like to also acknowledge Dr. Madhva Prasad, it was his initial brainchild to tell us that neonatal near-miss has been not that investigated as a topic. So as we all know, maternal and neonatal care have been two of the most important agendas of clinicians and policymakers all around the world. And that's why the United Nations came up with the Millennium Development Goals in the year 2000 to be achieved by 2015. And to reduce child mortality and improve maternal health were two of the 8 agendas on the list. But unfortunately, that was not fulfilled. As per the Indian scenario is considered, we contribute to around 17% of the global population and to around 16% of the maternal morbidity and 21% of the infant death. So that's a very big concern for us, and that's why we have to really prioritize on improving the maternal and neonatal health. The challenges that we face is that despite all the efforts, all the national schemes that have been implemented, the targets of reducing child and maternal mortality ratios have still not been met as per the set expectations. WHO has put in sustainable development goals after the MDG did not achieve the targets, and these have to be achieved by the year 2030, which say that to reduce the neonatal mortality by 12 per 1,000 live births in all the countries. So we have some major hurdles in the achievement of this target, which we have to overcome. And considering this, there was an introduction of a definition called as maternal near-miss mortality, which was a tool for monitoring the quality of the maternity services and trying to bridge the gap in the deficiencies between the implementation of the policies and the healthcare services that we provide. So next slide, please. Based on similar definition of the maternal near-miss cases, there was another new indicator that was evolving was the neonatal near-miss cases. Now, the definition of near-miss cases came up because they share similar factors and characteristics as the deaths, that is the mortality cases, but they are much more in number. That's why we get a bigger cohort to research from. and you can extrapolate the findings to prevent them going into the mortality cases. So neonatal near miss is defined as an infant who nearly died but survived a severe complication that occurred during pregnancy, birth, or within 7 days of extrauterine life. So they are much more in proportion as compared to the neonatal deaths, which are comparatively smaller and hence give us a better cohort to research on. Next slide, please. I cannot see the screen.
Ratna ma'am, the screen is gone.
Pragna, are you there?
Ma'am, can you see my screen?
Yes, yes, Pragna.
Yeah. So can you see it now? Quite
Yes.
right?
Oh, 1 minute, ma'am. I think at my end it got frozen. Yes, ma'am. So that's why we came up with the research on the neonatal near miss cases. And what we saw was that in most of the factors that were affecting these neonatal near miss cases were primary obstetric causes, which had an adverse effect on the fetal outcome, like low socio-demographic history of the patients, registration history of the patients, the disorders specific to pregnancy, like gestational diabetes and hypertensive disorders, maternal medical disorders, and most importantly, the delays in the referral. The primary, secondary, and tertiary delay as per as the WHO referral system. And that's why, next slide, please. That's why we decided to use this as our rationale behind picking up this as the research topic, because many of these factors, the maternal factors and the lacunae, if we can identify and rectify them, we can really help with better healthcare facility in reducing the maternal neonatal morbidity rates. And this is how we came up with our objective. So the primary objective of our research was to calculate the incidence of neonatal near miss cases in comparison with the neonatal deaths, and to find out the indices of neonatal near miss rates as compared with the live birth, and the severe neonatal outcome rate as compared with the live birth. This would help us in comparing our data with these are standard definitions. So we can compare them with the existing studies in the literature and set a standard. And the secondary objectives were to elaborate different maternal factors, right from the social demographic and the obstetric characteristics in antenatal, intrapartum, and postpartum, and the birth variables that were influencing these neonatal near miss cases. And then most importantly, to find out the service-related delays which were influencing these neonatal near miss cases as per WHO model. Next slide, please. So we conducted the study over the period of 1 year from 1st of September 2018 to 31st of August 2019. And it was a retrospective descriptive study. And the sampling of the neonatal near miss cases, we selected the neonatal near miss cases from the entire data as far as the pragmatic criteria. So this pragmatic criteria was given by a multi-country survey that was conducted by WHO. There were 2 studies that were conducted by WHO in over 25 countries and then 29 countries, and they created a big data set and gave out 2 definitions to select neonatal near miss cases. One was the pragmatic criteria and the other one was the management criteria. So I'll talk about it a little in detail further, but we selected according to the pragmatic criteria, and we entered the data in detailed case record forms and took the data from the medical record books. We got the IC permission, there was no conflict of interest, and then we used descriptive statistics to analyze the data. Next slide, please. So the indicators, previous slide. The indicators that we studied were, as per the pragmatic criteria, that the incidence of neonatal near miss cases, they have to survive till the 7th day after birth, and they have to fit in either of the 3 criteria. So the birth weight, has to be less than 1750 grams. The APGAR score has to be 7 or less at 5th minute, and the gestational age has to be less than 33 weeks. And the other indices that we studied was calculate the neonatal near miss rate as per the 1000 live births, severe neonatal outcome as per 1000 live births. And the 3 delay WHO model that we took into consideration was the first delay is a delay in decision to access the medical care, that this is on part of the patient. The secondary delay is when there is a delay in identifying and reaching a healthcare facility for managing such obstetric emergencies. And the third delay is a delay in receiving appropriate treatment after the patient reaches the tertiary level hospital. So these are the delays that we studied, and the socio-demographic data was studied as per modified Kupuswamy scale. Next slide, please. So I will discuss the results and the comparison with the existing literature as well. So the first that we found out was, if you can see in the table, the number of near miss cases that we found out over 1 year were 810 out of the 6,383 live births that we had, and 231 neonatal deaths that we had in the hospital. So birth weight was responsible in 30.25% of the neonatal near miss cases. And this was similar to the other studies in the literature, like the one Brazilian study, which was a big study of 2,500 patients, which also gave out a similar result that tells us that lesser the birth weight, for the prognosis. In combination, birth weight and gestational age less than 33 weeks contributed to 47.28%. Next slide, please. So this is the management criteria, the second criteria that I was talking about, which was given by the WHO data set. Now, if we took into consideration the management criteria, it makes it very complicated because it involves all the management steps that are taken when the neonate is admitted and are required. So the problem with selecting management criteria as a part of research is that the management protocols differ in different institutes. It's difficult to compare the results between two institutes if you take into consideration the management criteria, and it gets very complicated. So pragmatic criteria is a simpler criteria to select. You can use it in retrospective studies. And there have been recent studies by Kale et al. To check the validity of using only pragmatic criteria exclusively as the factor to select the neonatal near miss cases, and they have found significant specificity and sensitivity for that. So that's why we have picked it up. But a combination of pragmatic and management criteria by establishing some standard guidelines would be better for future studies. Next slide, please. So as you can see in the slide, the maternal factors which affected these neonatal near miss cases, the first is the age. So we found out that the commonest age group that the mothers belonged to was 20 to 35. 88.6% of the women belonged to this age group. And this is very similar to one of the biggest studies made on neonatal near miss by Sylvia et al., which showed similar results. Some previous studies have stated that extremes of age group, either adolescent or older age groups, show higher morbidity and mortality, both neonatal and maternal. So maybe our result also corroborates with same, that 20 to 35 gave rise to more near miss cases and not mortality cases. Also, the number of adolescent pregnancies in our study was much lesser as compared to the Western studies, maybe because of cultural differences and the stigmata that is associated with unmarried pregnancies in our society. The parity that we saw was we found primiparous patients more commonly in our research. And as per the duration between the current and the last pregnancy, we saw that less than 2 years, 63% of the patients were in less than 2 years, which is a very big number. And it showed that poor prognosis was associated with lesser the duration time gap between the two pregnancies. And this is well established in previous literatures as well. So our results were similar to that. The ANC registration, we found that we had 95.4%. That's a good number. It seems like a good number that the patients were registered in some or the other hospital, and 32 patients were completely unregistered. When they presented during labor, they were completely unregistered. But the time of registration and the number of ANC visits, the minimum number of ANC visits as per WHO, were much lesser. So only 34% of the patients were still they registered after the age of 20 weeks of gestation, and almost 28.3% of the patients did not have adequate ANC visits, that is, they were less than 3. So this was another finding that we found, the result that in our research, which may have led to the near miss cases. So the history of hospitalization of these mothers at some point in time in their antenatal period was seen in almost 29% of the women, where 16 women required ICU admissions as well. These results are consistent with the previous studies, which show that hospitalization at any time during pregnancy was associated with increased chances of hypoxia and the perinatal infections. So that also corroborated with the previous results. And if you see the number of patients that we had, the registrations that we had, only 27% of the entire cohort, the mothers, were registered at our hospital. 72% of the patients were referred for some or the other high risk from the other hospitals. And maybe that's because that could lead to one of the biases in the results, where we have some higher number of referrals and higher number of complications. The type of the pregnancy that we saw was singleton pregnancy were the maximum, and spontaneous conception was found the maximum in our research in almost 82% of the cases. Next slide, please. So if you see, the neonatal near miss cases were seen in more in the women who had induction of labor for some or the other reason, which was commonly seen in uncontrolled hypertensive patients and PPROM and fetal growth retardation. And spontaneous pregnancies was seen in 42.8% of the women, whereas induction was seen in 57.2% of them. Next slide, please. The rate of the cesarean section that we saw was much higher. It was 61.97%, which is a very big number. It was much higher than the WHO recommended rate, and out of which the majority were undertaken on an emergency basis for various indications like distress, antepartum hemorrhage, etc. So the previous studies that were conducted in Brazil and Africa, and as well as the WHO data set, all of them showed that neonates delivered by cesarean section had higher neonatal near miss rates as compared to vaginal delivery. But again, this could be a selection bias at our hospital, because the rate, it was a tertiary referral center and all the high-risk patients were referred, so which required immediate intervention. So that's why probably the cesarean section rate was much higher. And as you can see, the steroid completion rate, in spite of majority of the patients being in preterm, only 49.2% of the patients had completed steroid that is advised as per WHO, and the others did not, which could be one of the reasons for complications seen, the respiratory and the other complications seen in the neonate later. Next slide, please. So out of the entire cohort, only 25% of the patients were low-risk mothers. 74% of the patients had at least one or the other comorbidities associated. So the highest that we saw in our cohort was anemia. So it was mild or moderate to severe. That was the highest comorbidity that we saw in our, despite all the government policy implementations and free iron distribution to patients, still we had moderate to severe anemia in 114 patients, that is 21%, and mild anemia in 153 patients with 28.92%. And it was followed secondly by the hypertensive disorders, that is PH, preeclampsia, eclampsia, and chronic hypertension in combination. Next slide, please. So the other birth variables and indices that we studied in this, you can see that the gestational age at birth was in majority of the patients less than 37 weeks, that is, they were preterms, contributing to neonatal near miss cases in 94.56% of the patients. And as you can see, the live birth rate at our institute was 6,383. And in comparison to that, the neonatal deaths were 231 and the neonatal near miss that we found were 810. So our study found out that neonatal near miss cases were 3.5 times more than the neonatal death cases. And this is exactly what the other studies in the literature had suggested, that neonatal near miss cases is a better indicator for conducting audits and looking at the fallacies in the treatment facilities, because there would be around 4 times more than the number of the deaths. So our results are again corroborating with the literature. Next slide, please. The socio-demographic data of the mothers, we found out that most of the women belong to the low socioeconomic strata. But again, most of the patient population presenting to a public tertiary hospital like ours belong to the poorer socioeconomic groups. So again, this data was slightly a little variable from the Western world studies as well. Next slide, please. So the referrals that we saw were that 72% of the patients in our study were referred for some of the other reason, and the maximum of them were referred for threatened preterm or preterm in labor or premature rupture of membranes with non-availability of the ICU, followed by hypertensive disorders of pregnancy. So this was the maximum, this is the highest number of patients were referred for this reason. And the primary delay, the number of delays that we saw in our patients, almost 83% of the mothers out of the entire cohort had some or the other type of delay. So we had 54% of them, that is the largest delay that we saw was primary delay, where it was the delay was on behalf of some or the other reason because of the patient. And then that was followed by 23% in the secondary delay, and tertiary delay contributed to only around 6%, which was very less. Next slide, please. So primary delay was seen in 176 women, that is 54%, where either it was because the mother did not register or she failed to register on time, she did not have regular ANC follow-ups, where problems like anemia, hypertension, fetal growth retardation, maternal infections would have been picked up and treated on time to prevent the neonatal near miss rates. The mothers at times were not aware, not educated about the proper antenatal care and visits, or at times they were advised admissions for different medical reasons, but they refused admissions due to the socioeconomic status in their homes, and they were non-compliant with the treatment protocols. So it is very unfortunate to see that despite Indian government giving away free iron tablets, for example, under the national program at public hospitals, we still had 267 women in our study who had anemia, and out of them 184 required parenteral or blood transfusions in the peripartum period, which increased the neonatal near miss cases. So these are the things, the primary delays that we can work upon to bridge the gap between the healthcare system. Next slide, please. Secondary delay contributed to 23% of the delays. Now, this highlights the deficiencies in the referral systems, which we see very commonly in the public hospitals in our setups. So the reasons that we found out was that they could be because there was less staff with critical limitations of facilities like non-availability of ORs, blood banks, NICU, especially the NICU in the PPROM patients. And we saw that the referral chain was not being followed, which led to multiple hospital visits before the patient finally reached the tertiary center where she was admitted, because the NICU was not available at many places. And basic management was not offered before referring the patient. Like, for example, if it was a PPROM, even steroids were not given to the patient before referring her, and it took hours before she reached the final tertiary center. And this complicated the case further. There were other causes for the secondary delay, such as delayed decision making on the part of the team in the periphery. lack of ambulance facilities, prolonged travel time because of traffic, especially in the city, and similarly. So these things can definitely be worked upon to some extent. Next slide, please. The tertiary delay was seen only in 6.54% of the patients. So, and that too, namely, the time that we saw the delay was because of time taken for arrangement of blood and blood products, which delayed the operative interventions. And some delay was because of intrapartum monitoring errors by the junior doctors. So this overall shows us that how deep and multivariate the problems lie, and how easy it is to blame the team that is handling the patient, but the problems are actually very deep rooted, and they start right from the primary delay and coming up to the tertiary delay, which was the least amongst all three delays. Next slide, please. So the strength of this study was that we proved that neonatal near miss could be an effective indicator and a tool for quality control and audits of the implementations of the different policies that we have in place, to see if there are protocols that are being followed, to select the patients, the cohort, and to see the maternal factors impacting these neonatal near miss cases. And in fact, there have been many studies that have been conducted on maternal near miss cases globally as well as in India, but neonatal near miss cases have been, it's a topic that has been largely unexplored. There are hardly any studies conducted in Asian countries, especially in India. This is one of the first studies that has been conducted in our country. So the data is really scarce, and we can definitely use this as a tool to improve the neonatal and maternal care. And that was our rationale behind choosing this topic as a study. And the limitations of our study is that we found out that congenital anomalies need a better classification in more detail to be included or excluded from the study, because there are certain major ones where severe morbidity and mortality cannot be prevented, and they're still counted in near miss or maternal deaths. So in our case, we had 16 congenital anomalies, but 6 of them were severe enough where we could not do anything to save despite best interventions. The second limitation that we found out, that the pragmatic criteria that we used suggests that we select the neonates that survived up to the first 7 days of life. But not all of these survives through the entire neonatal period. So there have to be a uniform standard definition, just like the maternal near miss. The study design, at the end of the study, what we felt was that if we, in the further studies, if we try to compare it like a case control study design and compare the neonatal near miss along with the healthy neonates, we can get a p-value, significant p-value, and we can have better results, and we can interpret them in a better manner. So I conclude by saying that the study has managed to depict the lacunae in the system and how the various maternal factors impact the neonatal near miss cases. So there are definitely the preventable factors that we found out were the inadequate antenatal registrations and follow-ups, non-adherence to the simple treatment, advised treatment like iron tablets and blood pressure tablets that were given to the patients, reluctance for hospital admissions, improper referral systems, unavailability of NICU leading to a significant primary and secondary delays. And if rectified on time, we can significantly bring down the neonatal morbidity and mortality in our setup. And neonatal near miss can be used as an effective tool for quality control. And the sample size would be much larger than studying only the neonatal deaths, just that the definition needs more standardization globally. Next slide, please. So this is the need of the hour, that we conduct regular audits and include neonatal near miss as one of the indicators. And we need a better surveillance of the health programs, the implementation of these programs, and focusing on the NICU facilities of the peripheral hospitals, encouraging blood donation drives for easy blood availability so that it reduces the tertiary delay that we had at our setup, increasing educational and awareness programs for the mothers and their families so that we can reduce the primary delay, maybe at the time of the registration or maybe in the society, and setting up standardized treatment protocols for including the management criteria also as a part of the further research. Next slide. Yeah, these were our references, and yeah, thank you for your patient listening.
for your nice presentation.
Thank you, sir.
I hope you understand little bit of Hangubal.
Very little, sir.
Okay, okay. Enjoying your stay in Korea.
Yes, yes,
Okay, okay. I think your paper is open for discussion.
yeah.
Excellent presentation, Dr. Maitri. You have rightly
Thank
said
you.
it's the prematurity which is the greatest factor for neonatal near miss. Basically, what happens, maternal health is very important for a good neonatal health. And we have to bridge this gap between the maternal health. As you said, rightly said, that there were quite a few patients who were unbooked, and that led to neonatal near miss. And we have to make our mothers understand that antenatal checkups are not only for their health, it is for to make them healthy so that they can produce a healthy baby. Maternal comorbidities like preeclampsia, anemia, gestational diabetes, or other factors like they had renal disease or liver diseases, all these can all compound and give problems for the neonatal health. Because these are the patients who come unattended, they had inadequate antenatal checkups, they had inadequate maternal health, the simple things like they're not even taking iron tablets. And you have to impress upon them that these tablets are not given for the maternal health only. They are for making the baby's iron stores as well. Because you have to make them understand that this iron capsules, they are not only going to help the mother to prevent anemia, but also because initial 6 months of the life units, they will not get only, they will just be getting breastfeeding, which is a very poor source of iron. So at every step, at every antenatal checkups, you have to impress upon the mothers the importance of neonatal health. That is what we have to impress upon. And of course, there are problems. There can be preeclampsia, there can be fetal growth restrictions, there will be diabetes. You have to prevent them and manage them adequately. And as you said, the primary delay, secondary delay, tertiary delay has to be addressed at all levels. So it is not only the awareness among the mothers or their families, but also among the awareness among the healthcare workers. Quick referral, quick attendance, and no delay in the management of the patients. That will go a long way in taking care of the maternal as well as the neonatal health. Excellent presentation and excellent observation. I must congratulate you for your excellent paper.
Thank you.
Is Dr. Sushil Chawla around so he can give also comments? No, no. Arun, you would like to give some comments?
I think she has highlighted the important aspects where there can be delay and the importance of educating society so that they can come to hospital at the earliest so we can have improvement in perinatal mortality rate.
Yeah. We have always talked about a near miss condition of mother, but this is a really good paper of talking about a neonatal near miss. And it's really highlighting us, everybody, not only the our readers, but everybody who's attending over here, that this neonatal near miss is how important it is. And as you have pointed out, that our mothers, more than 50% mothers are anemic. That is, one of the biggest contributor of this neonatal near miss condition. And you also mentioned, I liked your that index, pragmatic index of WHO, then how you define the neonatal near miss condition. That is, you take a weight less than 1.75 kg, then your gestational age less than 33 weeks, and Abghar score less than 7. So it also includes the term as well as the preterm babies and mature and overdate babies. So that was a good thing because other indexes, they are very complicated, depends upon investigation, management, everything. So this was a real good condition, and you have definitely defined as 7 days if they survive, then they are near miss newborns. So this was a very good presentation, and you said the 51% were LSCS, but when there is a feature distress, when there are other conditions, the LSCS rate is going to increase. And secondly, there are in a tertiary care, there are many more reference. So they are patient. So naturally, the rate of C-section is going to increase. So we say that we have to optimize the C-section, but in certain condition, we just can't avoid the cesarean section. And WHO even have said that in 1985 that 15% should not be more than 15%. But recently 2018 WHO is saying that you should offer the cesarean section to all mothers who are in need rather than striving that particular rate. So we have to understand we are answerable, we are accountable to our patient and relative, and with the improved infrastructure, the LSAS rate is going to rise. And nowadays the norm of 1 or 2 children, and the parents want best of their children to have. So take it should be individualized. So you don't think that cesarean section rate is high. It is excellent presentation. And Madhva has joined. He is there. So Madhva, you are the Dr. Madhva. You are the
Yes, ma'am.
So we would like to hear from you.
Yes, ma'am. So, for the audience, what I wanted to say was, through this meeting, we also want to tell that we have to collaborate with other departments. Like this at a superficial look, this looks like a neonatal topic, but actually, this is bringing out the flaws in the Department of Obstetrics. What the improvement methods in the obstetrics department. So basically, what we are interested is to look at every day we are doing audits and improvement. Ultimate goal is to improve our patient care and systems. So through this paper, actually, what Dr. Parulekar has brought out is a newer method to look at our performance. Right. So initially we were looking only at mortality as a criteria, but here that near miss concept. It's these are so constantly people are coming out with different methods to look at improvements. So how it is working in our own systems is a very nice way forward in research, and I think these are the kind of papers that probably.
Thank you, Dr. Madhva.
More interested in published globally or proposed globally.
Your voice is breaking, Dr. Madhva. Your voice is breaking.
How they are working in India. Hello.
We can hear you.
Especially simple delays like giving steroids. Like patient were referred, but had they given the steroid and then referred, would have really had some difference in the management of the neonates.
Some time,
we
at
have
least
to
it was hours.
make our healthcare workers also aware of these points before they refer the cases. This is secondary delay, tertiary delay. All these things have to be taken into account, and then only we can bridge the gap between the good health and the tertiary care health.
I would like to comment on Dr. Madhva Prasad that we only get worried about a neonatologist, but we have whenever there is a perinatal mortality, we always in our institute, we always have a meeting for that. How we have for maternal mortality. Similarly, there is a perinatal mortality meeting also we have, and where we combine our neonatologists as well as the obstetrician to find out what is the best for the next patient when such thing arises. So there are auditing is happening, there are meetings happening, and we have good outcome nowadays with all good care at the obstetric level and as a neonatal care, and we are having good outcome of our patient and babies. So anybody else would like to comment? From my team also, editor, the secretary team, and other people. Kiran Mai is also there, Kalpana. Anybody would like to comment something, Nidhi?
Ma'am, I would just like to add that if we in such a study, if we combine, if we take in the neonatal ICU team, then along with the pragmatic criteria, we can also include the management criteria, which they can define better. And then as a research, it would yield much better results than only the pragmatic criteria.
So we are giving you this job that since you are attached to the still to the tertiary care, so we are giving you the job. So I want you to upload another paper with the neonatology care and let us come out with the best thing.
Thank you.
Anybody would like to say? Otherwise,
Ma'am,
Yeah.
good evening. Congratulations, Dr. Maitri. It is really a wonderful concept, as you have described. We have been doing MPDSR, ma'am, maternal perinatal death surveillance response, where we are combining both mother and baby, but it is a mortality. And we are doing separately near miss, maternal near miss. So this neonatal EMS, to understand the obstetric, pitfalls or scope for improvement, I think that is taking forward the mortality part of it into EMS, both for mother and the baby. So really wonderful.
Thank you.
So, Maria, can you display the next slide? Next slide, please. Yeah, so I think I must congratulate our speakers, authors, Dr. Mahesh and Dr. Maitri, for the excellent paper and even excellent presentation. I really thank our chairperson, Dr. Arun, Dr. Mala and Sushil for giving their excellent inputs. And the youngsters who are here, who have logged in, they get a proper message, what is, to be done. And if they're interested, the whole idea is that they can have a similar study. Basically, we want our junior to inspire from this episode to have more publication, and they can also have similar study that they can always take the author's guidelines what they can do. So that is the whole idea about it, and I'm really thankful to all my editors and chief guests, Dr. Jaideep, Dr. Nandita, guest of honor, Dr. Suvarna, and all my editorial board and national corresponding editor and reviewer and all my dear friends from FOGSI. And of course, I cannot forget my secretary, Dr. Supe, both Pragna, Supe as well as the Changale, Sunil and Gaurav for conducting excellently this webinar. And I really you're congratulating me, but I'm part of it. Maria from the our FOGSI, administrative side, she's really working very hard to make this program absolutely successful. And I'm really thankful to her, and I'm really always say in my all the meeting, she's asset to our journal. So thank you everybody. Looking forward, you just pass the message about the cover page design and tell them to upload, let them to send on the email ID of journalobgyn@gmail.com before 10th of May. So I thank all of you for the joining and enjoying this webinar. Thank you once again to all of
Thank you, Madhuri.
Thank you.
Thank you.
Thanks,
Thank you.
everyone. Good evening and goodbye.
Goodbye.
Nice presentations. Thank
Thank you, ma'am.
Yeah.
Thank you.
Thank you, ma'am.
Thank you.
Hi. Madhua, hi. Yeah, hi. We'll catch up on Friday. Thanks.